All right, guys. So I'm here with Dr. Kyle Gillette, who basically I've come to know him over the years for from his time with Merrick Health. So I worked with Merrick for a while, and then he went off on his own, and he's really helped me over the last year or two with my heart health and getting everything dialed in as far as that goes. So I wanted to bring him on, and you guys know I don't do podcasts too much anymore, but I thought this was the kind of thing that everybody needed to see, everybody needed to hear about. Um, I take my heart health very serious, and given my history with PEDs and all of that, I just figured this was a road we needed to go down. So I'm happy to have him on. Welcome him to the program. And um, basically, the first question I wanted to ask you was, what kind of is like the gold standard as far as heart health? What should people be looking at?
Yeah, it's a great question. In fact, there was a recent trial for patients that are taking TRT called the Traverse trial. And my colleague James and I kind of broke this down among a host of other trials. But the headline was TRT is heart safe. But if you actually look into it, there's a lot of different types of heart health. And the main ones are basically plaque, which physicians call ischemic or ASCVD, cardiovascular disease. So you have plaque heart disease, you have electrical heart disease, and you have congestive heart disease. But even within congestive heart disease, you can have dilated cardiomyopathy, which is where the chambers are too big, and then you could have hypertrophic cardiomyopathy. And a lot of famous bodybuilders have had these diagnosed, both they've talked about it publicly or in other cases, sadly diagnosed on autopsy. So you can have ventricles too thick, too big, and then you can have plaque in the coronaries, which is the arteries that go to the heart, and you can have the electrical system messed up. So the one that we're mainly talking about, because I know you like to talk about LP little a and ApoB and other things like that. And I know that we've discussed Dallas McCarver, who was extremely young, but still had a ton of plaque in his heart when it was analyzed. Um, when you're thinking about that for a young patient, it hasn't had time to calcify that plaque. So the best way to see uncalcified plaque is an invasive catheterization. They take it to the cath lab, which is actually quite dangerous. They look inside your vessels and put a little probe in the heart. So most people don't want to do that. So instead, they get something called a CCTA, which is they put iodine in your vein and they wait till it's in the coronaries and take a picture.
Okay, so CCTA, and that's what I had done about 2 months ago. Um, and really anybody out there, I think it's something that's worth doing. And it's not something we're going to get checked every 10 years, or it might be every 10, 15 years. It won't be every year. It's not going to be something very frequent. So I know there's somewhat, of radiation exposure and things of that nature, but done, you know, once a decade or more than that even, it's going to be worth seeing in my opinion, especially for those of you who are on PEDs. I know the vast majority of the audience here is not, but if anybody has a family history of this or anything like that, I think it's worth looking into. So I'm really happy that I got it done. I felt like I cleared up a lot of loose ends as far as the damage from PEDs and all that sort of stuff. Pretty much most of you guys know my background on that. Uh, what do you think about, and we'll get into that in a second, we'll get into the CCTA. What do you think about the value of things like echocardiograms and stress tests and things of that nature?
In some cases, they can be valuable. And if you're thinking about a patient that is a more typical presenter of plaque related heart disease, again, ischemic heart disease or ASCVD, atherosclerosis, cardiovascular disease, then often they do something like a treadmill stress test, which is better than the injection that they use, or a stress echo to see if there's areas of the heart that have shown signs that they're already low in oxygen. However, in general, the younger and healthier the patient, the more likely you will to have a false negative stress test or stress echo, or especially calcium score. Generally, calcium scores are all going to be zero, which I know yours was actually not zero, but generally they're going to be zero until you're 55, 60, 65 years of age.
Yeah, so that's the interesting thing. So it was after Dallas had passed, and I went to get a calcium score done because it's a fairly cheap procedure. It's like $100. It takes a minute, not even. Um, and my score came back at 2. So I was 27 years old at the time. So what does that mean exactly? And where should it be at that age?
Yeah, it should be zero. It means that your heart is more like the heart of a 50-year-old or 55-year-old. And it could mean that you have a huge amount of uncalcified plaque that just hasn't converted to calcified plaque. In fact, we think that uncalcified plaque could be or often is less stable than calcified plaque.
Yeah, so that was the interesting thing. So this was kind of in that period where I had blasted PEDs for about 7 years at that point, lots of tren. I just come off using trenbolone for a 3 year period. So it did come back as a two, which I know I believe it was Antoine Vaillant who said, the bodybuilder, his was like off the charts. I want to say in the hundreds. It was like something like 1,000. I've heard of people around me with theirs being 1,000.
Yep.
And that's just a crazy amount of calcified plaque, but that doesn't even take into account the non-calcified, which is the plaque that can really rupture and cause the heart attacks. What's the
Yeah.
highest? Yo, you go ahead.
Yeah. The calcified plaque being high like that is certainly a red flag and warrants further intervention. But I've even had patients that have calcium scores of zero. I've had males in their early 40s with some risk factors. That's why you order the more invasive imaging. Of course, you've mentioned a lot of your risk factors, but I've had them had a calcium score of zero and a 70% blockage in their left anterior descending, which is known as the widowmaker, which isn't necessarily stented, but in that situation, you can do something called a fractional flow reserve, or you can see how it's flowing through that blockage, and then you can tell even without, in cases, some cases without a heart cath, if that patient is likely to benefit from a stent or other intervention like a CABG.
Yeah, that's wild. And I think the crazy thing is seeing that very young people can have these heart attacks and have these blockages and all sorts of these issues. Um, and one of the risk factors for that is the LP little a, lipoprotein little a, which at my level, it's always like 240 to 260 um, nmol per liter. And I think that's pretty much sky high as far as that goes. What's the highest you've seen as far as that? And what risk factor does that present? What does that do?
Yeah, I've seen 500s, and a lot of this is genetic. It's often on chromosome 6. If you check someone who's already high when they're pregnant, females, of course, then it'll often double during pregnancy and almost always follows SHBG, which is a protein that binds androgens and estrogens. That's actually one of the potential benefits of androgen therapy or TRT or even oxandrolone is that it decreases LP little a significantly, or it can decrease in a lot of patients. And other things like HCG, PCSK9 inhibitors, aspirin, some niacin derivatives can also slightly decrease LP little a. And in some cases, weaker androgens like DHEA also decrease LP little a. I know mine's gone from about 100 nanomoles per liter to about 25 to 30. And in a lot of patients, I'm able to
Wow.
bring it down at least half of what it previously has been. But if it, of course, depends on their genetics and their and also their particle size. A lot of labs test LP little a milligram per deciliter,
Mhm.
which is a weight rather than a particle number. And it's best to check your particle number or both, and you can estimate your particle size. But I've put all the type of LP little a test that you want. You don't need to remember. If people want to go to my website or a website that orders the nanomole per liter for LP little a, I think it's something like $8 or $10 to test. And if they want their ApoB with it and their lipid panel and their fasting insulin and their CRP, that's what I call a lipid panel. And I'm pretty sure it's $20 even for
Oh my
people who
gosh.
aren't patients or members for to get all of those, however many 10 or 11 biomarkers. So if people want to test the LP little a, even in academic centers for people at risk, less than 3% of people get their LP little a tested, but about 25% of people have high LP little a. For guys that are kind of on the line, yes, when you're at much older age, if you let your LP little a be very high over the course of a lifespan, it is an independent risk factor for erectile dysfunction as well. So there's lots of reasons to check LP little a.
So that's crazy. And that's one of the reasons I even thought at one point about, man, maybe I should go on HRT at some point to try to get that LP little a down. because I have heard that's one of the things that really brings it down, along with an interesting one. I've heard saturated fat. I've seen some of the studies where saturated fat, high intake of saturated fat actually drives it down. But then you get where saturated fat drives up your LDL. So it's kind of like this difficult situation. It's like high saturated fat, you lower your LPA a little, quite a bit, but you drive the LDL up. So pick your poison. So what is the main like mechanism of what LP little a does that causes issues? Does it just cause more plaque buildup?
Yeah, so you can think of LP little a and ApoB as atherogenic particles. To the layman, the best way to explain this is they're the blocks. So the reason why my cardiovascular $20 panel or whatnot includes fasting insulin and CRP is because insulin resistance and inflammation are the glue that holds the blocks together. But if you do things like get immunizations or get a viral illness, then your CRP is going to transiently increase. So nobody is low inflammation their entire life, and you're not going to, optimize your atherogenic particles just when you're inflamed or just when you're sick. So the LP little a is a particle that is likely to get stuck in that plaque wall. So more blocks, more plaque wall.
Yes, it's like from what I've seen structurally, it's like a LDL particle with a fishtail on it, and that gets lodged in the artery walls to a greater extent, basically. I think that's what I've seen because I've tried to read everything there is possibly to know about it over the years. And I've experimented with different things and been really unable to budget, period. So it's one of those things that's kind of irritating because it's more of a genetic factor, as you said. But uh, maybe I've also seen, I believe I read possibly in the state of like low inflammation, it doesn't cause as much damage, and that might be one thing that neutralizes it by keeping
Yep.
the C-reactive protein down. We can keep overall systemic inflammation down and maybe not get as much of a problem from it. So what I mean, I feel like the things you just went over, those are kind of what I would say are the most important biomarkers that everybody should be checking. I check this stuff 3, 4 times a year, and I'm going to actually get my labs done probably in the next day or two with Dr. Gillette, and I'm going to check like insulin. I'm going to check C-reactive protein, all those things you just mentioned, because I feel like you always want to be checking your ApoB. LP little a is one of those things that it's not going to change a whole lot, but everybody should get that checked at some point. You just want to know what you're dealing with. And then fasted insulin is always a huge one for insulin sensitivity. And mine stays pretty low. It's usually under, 4 down upwards, all the way down to like 2. But that's something I like to monitor as well because I just you try to keep yourself in an insulin sensitive state with low inflammation, and generally you're going to be pretty healthy. Um, so I'll put a link to where you guys can get that checked out because I know I'm going to do it as well. And we'll, look at your blood work, take it serious. I think it's one of the things that it's like the evolution of fitness. We're seeing that where blood work is the name of the game. It doesn't tell necessarily everything. That's why I got the CCTA done, and we will expand on that. We'll check it out here in a second. I went with a Clearly scan, which shows the non-calcified plaque as well. But it's good to know about your health. It's one of those things you want to invest in. It's one of those things you want to be sure that you can go to sleep and you're going to wake up, and if you're going to go out for a run, you're going to be able to get through without having a heart attack, things of that nature. So everybody should kind of get this stuff looked at, and that's why I'm having Dr. Gillette on. That's why I think this is an important message to get out. Now let's go over the results of that angiogram here. So this is what we got, and I'll let
Yeah,
you kind of
so
explain it.
so the angiogram, that's where you put the dye in, and then they take a picture in your coronaries that kind of slow your heart rate down a little bit. Sometimes you're a bit lightheaded, and that just helps me get a better picture. And there's actually not too much to talk about in your scan because, shockingly, potentially even miraculously, your calcium score of 0 is now, or sorry, your calcium score of 2 is now 0. And you are one of the very few scans that I've seen, usually these are female patients, that do not have any risk factors, where you are zeros across the board, not even any uncalcified plaque. So normally here's where you'd see the calcified plaque. So you would expect this to progress to some degree, and you'd also expect to see non-calcified plaque, and hopefully not low density non-calcified plaque. This is usually less stable. And then you have a plaque stage. So some people might be familiar with breast cancer staging or prostate cancer staging. This is or breast cancer screening and prostate cancer screening staging. So, like a PI-RADS, BI-RADS. This is CAD-RADS, and here, of course, CAD-RADS 0. You have 0% atheroma volume. Normally, you get a millimeter cubed amount. For example, 77 cubic millimeters, it would say up here, your total plaque volume. And then it tells you if you're dominant or not. You're actually right dominant, so the right side is. And then it also shows you every single potential vessel. Some people don't have a ramus intermedius, for example, which is RI, or obtuse marginal number 2. So it tells you which ones you have, which is the bolded ones, and then which amount of stenosis you have. So again, this is extremely unusual for someone with your risk factors and a history of a positive calcium score to have 0.
So what do you think? How do you think that was possible that it could have reversed the calcium score and things of that nature? Is that something where vitamin K2 comes into play?
I
Or
do think that the vitamin K2, MK4, MK7 that you take helps. I do think that a lot of aerobic fitness has helped. Although a lot of times, if you study tribes like the Maasai, they do a lot of cardio and they just have bigger arteries that the blood flow is really good, but they still have the plaque as well. So remodeling from very low states of inflammation and also, great insulin sensitivity and probably everything else good with your lifestyle, good social support, good spiritual health. I think that all those things also make a difference. But as you can see, they did analyze your arteries. You can look at your arteries. They stretch these out with a program, and you look for plaque in here, and there's no red, no yellow, and no blue.
and then why? So why are some of the arteries in the pictures? Why does it narrow at certain points? Is that anything to worry about, or
No, generally this is where another branch will come off. So
okay?
the arteries around the heart, if you've seen a anatomical model of the heart, they're really twisty and kinky all over the place. This is generally where there's a bifurcation. For example, on your right coronary artery, it'll split off to your posterior descending and your posterior lateral branches. It's kind of like a river with tributaries. So
Okay.
that I think that's what this is. You can kind of see the iodine contrast dye going down this way and then off this way.
Yeah, and I mean, it is really kind of remarkable to look at this and see that. And I know what I did. I've talked about it with you in like 9 years of never coming off everything, 3 years straight running trenbolone, um, on high blood pressure that was not dialed in at all for that entire period. I mean, I think I was probably walking around at 180, 100 to 180, 110 on a consistent basis, just walking around. Because even now, being off everything, not being on TRT, doing cardio, eating healthy, being super lean, like this stuff, I still have a pretty high blood pressure naturally from genetics. Like I run 135, 140 over 85, 90 without any intervention. So to think that, how high was it all those years on PEDs? My lipids were probably sky high because anytime you take PEDs, your LDL goes through the roof, your HDL gets crushed. And
Yep.
generally, there's other things like C-reactive protein is going to be elevated the whole time from inflammation, things of that nature. So I'm sure my LDL was consistently 160, 170, 180. And I look at all this in the high LP little a, that's way higher than most people. 1 in 5 people tend to have an elevated level. And just all these unhealthy things that were going against me. And I think, how is this even possible now at age 33? And I really do, you guys have talked about it, my faith, and I have to give, credit to Lord and Savior Jesus Christ. Like, I think he literally
Mhm.
gave me a second chance. I think he healed my heart more or less. And I'm not going to be bashful about saying that. Like, this is an incredible miracle to me. Truthfully, I know you're open with your faith as well, and I just feel like this is not possible without him doing it. Because, like I said, I listed all those things, everything going against me, terrible diet as well. Like you guys have seen the videos. I ate donuts, whatever I wanted. There was no thought to any health factor whatsoever. So in my entire 20s, these things working against me, and here we are. I mean, how often have you seen a scan of that nature? Like, have you seen that in a male before? Or how common is that?
Now this is extremely rare, and I've never seen a male with your risk factors, and I've certainly never seen a male with a previous positive calcium score. Um, I think your calcium, I do think that your calcium score in the past was a true positive calcium score. Somehow, you've just remodeled that area positively, and I can't think of an explanation that excludes the miraculous. I do think it's a, a pretty miraculous uh, CCTA and clearly score result. I was shocked when I got it.
Yes, and that's why I'm just being completely transparent with this stuff. And I know some people are gonna, aren't gonna like that, but it doesn't make sense to me, truly. I prayed about this going into it. I was very concerned. I thought I was gonna have some definite plaque buildup, possibly some sizable blockages. I mean, there's no way
Yep.
around it. I abused my body recklessly for many years. Sleep apnea. We could keep going, guys. I could keep listing everything I did wrong. Sleep apnea for a decade at 250 pounds to 260 pounds walking around, all these things. And this is the result. It's not something I deserve. It's not something I expected. So I truly, give the glory to God in this situation. And that's why, you guys saw how in depth this is and what it shows you. And now I have the peace of mind to know when I'm out on a run and I'm maxing out my heart rate, doing like a tempo run or something, or a mile PR like I'm going to do in a couple of days, I know I have the peace of mind. Probably not going to keel over. I'm not going to have to worry about a heart attack. So that's one of those things where it's like that peace of mind of knowing with all these risk factors that I'm probably okay for a while. Maybe I'll have to get this done again at some point down the line, a decade, 2 decades, whatever. But it's one of the most valuable things I've done as far as I have a baseline. I know where everything's at. I know that pretty much if I continue on the healthy road I'm on, things are going to be okay. And I do think it is worth mentioning. Yes, I think like we touched on the lack of inflammation. And every time I've checked my C-reactive protein over the last couple of years since I came off, it's always been at the very bottom of the reference range to where it didn't register. So I think that plays a huge role. I think the lack of inflammation and I think the insulin sensitivity. I've prioritized that. Eating properly and cardio drive up your insulin sensitivity and your drive down your risk of, insulin resistance. So I've paid close attention to my fasted insulin level, and it's usually 2, 3, 4 in that range, never really above that. So I think those two factors have played probably the biggest role, along with possibly the vitamin K2 supplementation, which I haven't been doing very long. It's been about a year and a half, and I've been somewhat inconsistent with that until a year ago. And I've been doing 200 micrograms of that. So I know, do you tend to agree? Like it almost makes me think that with such a high LP little a level, and even, clinically, they might say LDL could be a little lower. I have 120-ish usually, 100 to 120 without statin intervention. ApoB is usually around 75, 80, which is decent. But it almost makes me believe, just looking at this anecdotal evidence, that inflammation and insulin sensitivity are maybe the two things that are what drive uh, cardiovascular disease as far as like taking care of it. What do you think?
Yeah. Yeah, they are. I see them as the literal glue that holds the blocks together. Um, but of course, if you're truly higher risk, if you don't investigate that further with advanced preventive imaging, then you are, in general, risking that
Yes.
you thought your insulin resistance and inflammation were good, because very few of us have labs all the way back into when we're a teenager to look at that. And a few other things that you can take away from this is uh, one, it's good that your outlook is this is something positive that happened to you. This is, a chance to emphasize good diet, good lifestyle, spiritual health, prayer, etc., rather than, you were just built different. So this is your card so that you can blast steroids again and, do whatever you want. So I think that's a good takeaway as well.
Yeah, I don't, I look at this like it's a second chance in life, so to speak, as far as my health, because as I said, everything should be damaged. I mean, I remember checking roughly a year ago cystatin C, which I check once a year usually, and my GFR was 131 or something ridiculous. So like the kidney function is perfect. The organs have been imaged before through a GI CT scan on two occasions because of my kidney stone issues, and everything was perfect, no enlargement, no issues. So it just feels like a second chance. And I'm not going to use that and be like, okay, we got the, all clear to lean into that former lifestyle.
Mhm.
Because I truly don't think this was me. I think this was the man above. And I think that it is a second chance and it's a chance to get the word out there. And I'm very happy with how it turned out. But I also just want to say, like, everyone should kind of look into this. I think it's very worthwhile. And you can go to Dr. Gillette and get all this stuff looked at. And that's what I think people should do. That's why I think this is so important. It's your health. Your health is the backbone of everything.
Mhm.
So, I'm going to continue to do what I'm doing and the cardio and implement all these lifestyle factors. But it's just really interesting to uh, see everything come full circle here. So let's, wrap up here in a little bit. Are there things you think people should get checked? What are the main things? Obviously, you've kind of touched on some of this, but is there anything in particular you want to say, like, this is the most important thing you want to seek out or
Yeah, I think at least once it's very reasonable to get a cardiovascular panel, which is what I mentioned earlier, lipids, ApoB, Lp(a), CRP, insulin. But in addition to that, if someone wants a general overarching health panel, then that's reasonable to get as well. It's quite simple. You can just go to a website and get it. In addition to that, if there's someone that has a profession, which a lot of people listening to this channel might do this, let's say they're a professional strongman competitor or whatever the case may be, to where it, regardless of what supplements or pills or whatnot that they need to use in order to be competitive, just being at a higher body weight for a long period of time, it's the same concept with our organic machines. Those are the bodies that God has made us with. They're each unique and they don't come with owner's manuals. And if we had a hyper complicated cars, especially if your car had to be huge, the bigger your car, the harder it breaks down. It is particularly important to speak with a knowledgeable healthcare provider and be open and honest about them, develop some sort of rapport, find some things in common to where you can enjoy chatting with each other rather than just being negative all the time and just feeling like you're sicker and sicker and sicker. So try to maintain that positive, stubborn resilience of I'm going to be fine no matter what. And then also at the same time, investigate things with your organic machine and find what you need to find.
yeah, and I think the fear of the unknown can eat at you. I know it did for me. Obviously, there were what I did, and I figured there were consequences to that, which I was content to live with. I accepted it. I'm like, there are consequences to what I did. But the unknown, like always wondering, how is it really, what's going on in there? Do I have issues? And so many of you have a family history. I know it. Like family history of heart disease is so common at this point. High blood pressure, all these things that it's worth checking out. So I'm really glad I did. It's just it's wild. And one other thing I should touch on, what do you think about like statin use and things of that nature?
Yeah, it's a good question. So statins are a tool like anything else. Um, Regardless of the lipid lowering therapy that you're talking, almost all lipid lowering therapies do have downsides and upsides. Ezetimibe probably has the least downsides, but statin therapy is usually indicated if you specifically have plaque buildup. And in your case, your ApoB is under 90, so that's pretty good. I don't think you've had an ApoE tested, and you don't necessarily have to. Sometimes you have a lower ApoB goal if you're ApoE4, E4, which is basically a neurodegenerative disease risk. But for a patient that does not have concerning plaque buildup, in general, statins are not necessary. And some patients do tolerate statins relatively well, but they're associated with muscle aches, joint aches, and also tendon pathologies. And ezetimibe is actually the only lipid lowering therapy that is not associated with tendon pathologies and tendon rupture. Again, associated,
Wow.
but I think the link is close enough to where even PCSK9 inhibitors can potentially be concerning for tendon rupture. They're just newer and more exciting medications.
Yes, and I have to say I've dabbled with Crest or rosuvastatin over the years. and I would take 10 milligrams. Generally, it's dosed up to 20 clinically every day, but I was taking 10 milligrams once a week. And even then, I saw about a 20 to 25% reduction in LDL. So that was really interesting. With no sides, I never felt anything. And I've experimented with it a little bit over the years. And so there are some better ones. I know like Lipitor tends to be a little harsher. That's where you see a lot of this the statin side effects come in, and that is the strongest one out there. Uh, the other thing I was going to say, so I've checked. I've had like a 23andMe done. I have the ApoE4 gene, one copy of it. Generally, people have 1 to 2 copies. And I think 2 copies puts you at like a 50 to two-thirds higher rate of Alzheimer's, whereas one copy is like a roughly 33%. Um, it
If
could
you
be wrong.
exercise, then your risk does not increase at all from one copy.
Okay, so that's something we'll want to expand on. So this was a concern of mine. Um, I have the ApoE4 gene. My grandmother had Alzheimer's. It's a concern with my mother. We're pretty sure that's where I get it from. And if anybody's seen Alzheimer's dementia, you know the toll that takes. And often the ApoE4 gene is tied to cardiovascular diseases as well. You see the
Yep.
crossover big time. That tends to give you the predisposition to the higher lipids and all that. But this is interesting. So you told me this, and I wanted to touch on that real quick. So basically, if someone has the ApoE4 gene and they're doing cardio or just exercise in general, what is it?
Yeah, so if someone's a heterozygote, an ApoE4 gene is actually a combo of two genes. And not that
Okay.
people need to remember that. They can just get it tested and find out. But if they're looking through their raw genome and they need to look at two different sites, basically, they're called SNPs. But the heterozygote status or carrier status is if you have one of two copies. And that does increase potentially your risk of late onset Alzheimer's dementia, but not necessarily other dementias. There's other risk factors. You mentioned that it was your maternal grandmother,
Right.
and there is a couple different risk genes, including SCHMOOSE, SCHMOOSE, that are on the mitochondria, but they're protective genes. So you probably don't have the protective genes on your mitochondria, given that people inherit all of their mitochondria from their maternal lineage. So perhaps you don't have those protective genes, but the more you exercise and actually the more lean body mass you have, Dr. Tommy Wood, who's a doctor and PhD as well, he's an expert in this topic, and you're already doing the things that have the biggest effect on decreasing your risk of dementia. I'd say probably 100 or 200 times stronger than if you're taking a statin or not. Lipid transport in the brain is very interesting, perhaps not to the people listening to this podcast, but basically the lipids can get stuck in your brain cell because the transporter is not working as well. So if your lipid levels are higher and higher and higher, then slightly more get stuck. And some statins cross the blood-brain barrier, some don't. Lipitor or atorvastatin does cross the blood-brain barrier. Rosuvastatin does not, which can be both good and bad. But I do prefer Crestor or rosuvastatin for patients who do choose or do want to go on a statin because they think that the benefit outweighs the risk. I used to be on rosuvastatin as well. I no longer am. I never felt any side effects, but eventually my Achilles tendinopathy got annoying enough to where I wanted to remove that as a potential confounding variable in my case.
That's really interesting. Okay. Makes a lot of sense. And I'm trying to think. I think that's about it. One last question I'll shoot at you. Um, Vitamin D blood levels. What is the ideal range, and is there such thing as too high?
Yeah, it's a great question. So, 25 hydroxy vitamin D is generally the type of vitamin D level that's checked. If you have kidney disease, certainly if you have significant kidney disease, or if your vitamin D homeostasis does not make sense, or if your calcium levels are abnormal, then it is also important to check a 1,25 hydroxy vitamin D. The liver activates vitamin D somewhat and changes it into 25 hydroxy vitamin D, and the kidneys further activate it into 1,25 hydroxy vitamin D. Most places where you're getting your labs checked, it's probably just the 25 hydroxy vitamin D. I know in our complete micronutrient panel, it includes a 125, But I do think it's important to take with vitamin K2 because high vitamin D levels and high calcium levels are actually associated, a correlation, not causation, with pretty bad things and outcomes, which is why people say vitamin D is toxic. But also, people who are taking a bunch of vitamin D are usually doing so for a reason. So, ideal vitamin D levels somewhere between about 50 and 100. And if you can take your vitamin D with a good source of K2, like MK4, MK7, that's ideal.
Okay, that's interesting. I seem to respond incredibly well to vitamin D supplementation to where this last panel I checked, I was taking 10,000 IUs twice a week and it was at 94. So it's just hyper responder as far as that goes. The one before that, I think was 103 on the chart, which I didn't even know it could go above 100, but I guess technically it can. So
Yep.
um, the only thing I worry about that was the possible causation with kidney stones. I don't know.
Mhm. Were your calcium levels high in the blood?
Blood calcium was pretty normal. So you think that's, but the calcium, the stones were calcium oxalate, and I don't know. It's just concerning.
Yeah.
But
Yeah. Kidney stones have a quite strong genetic um, link. And we used to prescribe HCTZ to help people pee out a little bit more calcium than normal. And I know that a lot of bodybuilders take their ancillary telmisartan, and in some cases, usually if they're also of African heritage, HCTZ might be a better choice. Again, because it helps them pee out a little bit more calcium, and then it also helps with cardiac remodeling in a slightly different way. But you do pee out a little bit more water, and then you retain uric acid. So it is kind of complicated. For example, if you, let's say you have kidney stones and blood pressure is a little on the higher end, and you're taking ancillary, you take the HCTZ for it, then you retain uric acid, then you get gout if you're predisposed to gout. So there's a lot of moving targets. But there are a lot of things that you can do for kidney stone predisposition.
that's good. Well, is there anything more you'd like to touch on? Anything you'd like to go over?
I don't think so. I appreciate the opportunity to talk. At the end of the day, I'm just here because I'm also trying to help people. I know that in the past, I've spoken with our mutual friend Derek about cases like Joe Linder. I know that a lot of our community was very sad when he passed as well. And frankly, when each person has a negative health event or passes. So I'll continue working on these projects and I'll send the links and whatnot. Um, but yeah, fortunately, God's blessed me as well. I'm able to feed my family with the Gillette Health Clinic. So in the future, I'll continue to promote getting these health services to the public with like extremely reasonable ethical margins, if that makes sense. So I appreciate the opportunity to help do that.
Yeah, and they truly are. These are the best prices you're going to find anywhere on the internet if you go through Dr. Gillette. So that's why I'm going to do it. I trust him. He's taught me so much, helped me out so much. And obviously we went over the CCTA, the angiogram, and that's something that I truly feel everyone should check because I think it would have saved a lot of these guys within the industry who passed away. A lot of this stuff would come up. It shows your, aorta and all that kind of stuff, aortic dissections, like what happened to Boston. And blockages and things of that nature. So definitely something that I feel is valuable and worth looking into. So I appreciate you for coming on and we'll get this message out. And I think it's really going to help a lot of people. And I'll put links of where they can find you. I'm going to put all that below if you want to go to Dr. Gillette's website or his Instagram, all that kind of stuff. Reach out to him and he'll help you out. Thanks, buddy.
Thank you. My pleasure.